Hello, everyone. It's my pleasure to present to you Acromegaly highlights from ENDO 2021. I'm Maria Fleseriu, a professor of medicine in the Division of Endocrinology, Diabetes, and Clinical Nutrition, and the professor of Neurological Surgery and director of the Pituitary Center at Oregon Health and Science University in Portland, Oregon. It's my pleasure to collaborate with CheckRare Rare Disease Continuing Education and American Academy of CME. The learning objectives for today are to describe the latest research being presented at ENDO 2021 to better manage acromegaly patients and their clinical relevance. The ENDO 2021 was an annual meeting focused on endocrine disorders and cancers overall, and usually it's a 4-day live event in March. This year, again, was virtual as all of our meetings. And it's important because in the last few decades, a considerable body of evidence supports the concept that patients with pituitary tumors would receive the best care from units of excellence. Multidisciplinary care in acromegaly requires a team approach. Us endocrinologists, but also neurosurgeons, general practitioners, radiation oncologists, neuroradiologists, neuro-ophthalmologists, oncologists. So we all collaborate for the better care of patients. Here, the goal is to keep updated all these healthcare professionals involved in care of acromegaly patients with the latest ENDO 2021 information. So what is acromegaly? It's a chronic, progressive, and potentially lethal disease if not treated. And it's due in the large majority of cases to a growth hormone secreting adenoma. It affects multiple organs and systems and often takes many, many years to be diagnosed, up to 11 years, and things did not change over time too much. This disease has numerous comorbidities, including type 2 diabetes, hypertension, heart disease, sleep apnea, arthritis, carpal tunnel syndrome, bone pain, and we found out more recently, including vertebral fractures. So the main goals of treatment are multifactorial. We have to normalize numbers, both growth hormone and IGF-1, reduce tumor size for the large majority of patients that have large tumors. We have to manage the symptoms and comorbidities and improve quality of life of patients in the same time. And I'm going to show you some recent data on that. And furthermore, we have to look at all the comorbidities and we try to reduce them and thus mortality overall. Most of the patients require multimodal treatment, surgery, medical therapy, radiation, or a combination of them overall. So one of the studies presented from UK at ENDO look at, are there any differences between quality of life of patients that undergo just surgery or they undergo both surgery and medical treatment? And they looked at, as you can see here, of several surveys, including the Acro Quality of Life scores, that's the most validated and used for many years now, the short form survey, the SF32, that's not validated for acromegaly, but we use it overall, the SF32 mental score, and the fatigue severity scale. And if you're looking on the left, we have the groups of surgery alone, and on the right, surgery and additional treatment, mostly medical treatment. So the groups were pretty similar in years with acromegaly. And if we look at the quality of life overall through AcroQLA was relatively similar. The physical score, the mental score, and also the fatigue severity scores. So despite some previous data showing that the surgery is better than medication, this group found that both of the groups had similar quality of life, and all scores, unfortunately, compare lower than those from healthy controls. So we have to do better to find better treatments. What medical treatment options we have available for acromegaly? And I'm pleased to say that over the last several years, we have many new medications approved. Octreotide subcutaneous, it's the older one. It has to be injected sub-Q. The efficacy is somewhere between 30 and 60. However, all the new data shows seems lower. And this is probably because some of the initial data patients were selected to be responsive. The octreotide LAR, that's an intramuscular medication, the oral octreotide that was recently FDA approved, the lanreotide, that's a deep subcutaneous medication that it's usually administered every 4 weeks. However, it's FDA approved for selected patients every 6 weeks, and also every 8 weeks. And all these first generation somatostatin analogs, or also called somatostatin receptor ligands, have somewhere efficacy between 30 and 60%, depending on which patients are selected. There are other new medications, including pasireotide LAR, that's a monthly intramuscular medication approved for several years now by FDA, and it's a newer generation of somatostatin receptor ligands that also has higher binding to receptors type 5. The adverse events are relatively similar with the other one, with the exception of hyperglycemia that's significantly higher. Pegvisomant, that's a subcutaneous medication now approved for many, many years. It's approved as daily. We're using off-label in combination therapy, sometimes twice a week or even weekly based on newer study. The initial study showed that efficacy is up to 90%. Later study in real life were a little bit lower. However, this is a very good medication when we need clinical control. And of course, sometimes we're using cabergoline off-label. So new data presented on some of these new medications at ENDO 2021. As we can expect, most of the data on new medications was on the new kid on the block, the oral octreotide. I had several abstracts. Most of them from the new phase 3 EMPOWER trials, and I will briefly review to you the design of the study. Patients with acromegaly that were previously treated with injectable, either octreotide or lanreotide, they had to be controlled. For this study, the control was IGF-1 less than 1.3 to account for the variability of IGF-1, and the mean growth hormone less than 2.5, was a 26-week run-in to find effective dose of oral octreotide, and then the patients were randomized to either oral octreotide or injectable octreotide or lanreotide. Also was a study looking at the extension data of previous study done mostly in US on oral octreotide optimal, that was the base for the FDA approval for this drug. And the extension, 40 patients continued, and the over 48 weeks, the IGF-1 levels remained stable, and there were no additional safety concern. How about the EMPOWERED? The study comparing, as a non-inferiority study, oral with injectable. The study met the primary endpoint, and the oral group, 91% of patients maintained response, and that was 100% in the injectable group. Furthermore, in a sub-study of patients that were not controlled initially on oral octreotide, they were able to have addition of cabergoline. And what's interesting is this worked out of 9 patients, 5 showed response. So it's possible that for few patients in real life, we'll be able to have a combination of just oral medication. How about other data from the EMPOWER study that was presented at the end of 2021? Importantly, looked at symptoms. So patients on oral octreotide, 73% maintain or reduce the acromegaly score, and 75% maintain or reduce the active symptoms that we know they're very important. Keep in mind, these are patients that are all controlled. Safety-wise, the oral octreotide also showed similar safety with the injectable. And patient satisfaction. The EMPOWER study showed that in the 26-week run-in phase, where all patients were on oral octreotide, 3 of 5 domains improved: emotional reaction, treatment convenience, and treatment satisfaction. And in the randomized phase, no change in satisfaction for the oral, and patients that were switched to injection had more anxiety and frustration due to the injection itself, because everything else was similar, as you know. Oral paltusotine. Paltusotine is a somatostatin receptor type 2 receptor agonist. studied in Acrobat-8 phase 2 study, single-arm, 13-week switch study of 25 patients. And these were patients that were taking the long-acting somatostatin receptor ligand, but had not reached normal IGF-1 and were switched to once-daily oral pituitary. The results were no change in IGF-1 over 13 weeks. New treatment could be similar to injectable, but further studies are needed. The treatment-emergent adverse events include headache, arthralgia, fatigue, peripheral swelling, paresthesias, and hyperhidrosis. These are symptoms that we all see in patients with acromegaly, and the phase 3 clinical trials is starting in 2021. How about pegvisomant? Pegvisomant, as I mentioned earlier, is a growth hormone receptor antagonist used either in monotherapy or in combination with somatostatin receptor ligands or dopamine agonists if they did not respond. This is a study, very large, from Boston group that looked at efficacy of pegvisomant over 6 months treatment period. And you see adding pegvisomant, monotherapy, 40% decrease, addition to somatostatin receptor ligands, 53% decrease, cabergoline 36%, and then all three, 47% decrease. And minor changes in blood pressure were observed in monotherapy group, and no changes observed in liver panel or A1C measurement, showing that this medication, either single or in combination, seems safe and significantly improves the biochemical control. At ENDO 2021 was also a study looking at large data from insurance claims, comparing patients with acromegaly, as you see here, over 1,000, with match controls over 5,000, actually more close to 6,000, and looking at their comorbidities overall. And as you can expect, but this was surprising, the cardiovascular disorders, hypopituitarism, sleep apnea, malignant neoplasm, and arthritis were significantly higher than age-matched control. Also, looking at the medications overall, these patients with acromegaly, as you can see, are taking many, many more medications than their counterparts in the match cohort. And if you look at the number of oral medications, this was 12 with a standard deviation of 10 and over 7 with standard deviation of 7. 79%, so almost 80% of patients with acromegaly are taking more than 3 oral medications. And this is similar with trends observed in the post-hoc analysis done from previous studies with liraglutide injectable done in Europe, both primaries and lead, showing that patients with acromegaly, due to comorbidities, they are taking many concomitant oral medication. And this is important when we think of what other type of therapy and should they continue their injectable therapy, for example, for acromegaly. If they're taking so many oral medications, what are the drug-drug interactions? Are they good candidates for switching some of these medications to something else? Other comorbidities have been studied and presented at ENDO 2021. On glucose metabolism was a study on 89 patients. The major risk factor for dysglycemia included age, male sex, obesity, and macroadenoma, and importantly, improved after surgery and medical therapy. A carpal tunnel syndrome study looking at patients with acromegaly, almost all of them showed some signs, more severe or moderate, of carpal tunnel syndrome. And interestingly, in a study of patients with acromegaly and anemia, 57% of patients were diagnosed with anemia. And there were some interesting correlation, looking forward to see the paper, between characteristics of tumor, hormonal status, type of treatment, and presence of cancer. How about COVID-19? This is in our life now for more than a year. There were no data specifically presented at ENDO on this topic with acromegaly. However, the comorbidities that I have mentioned earlier, including cardiovascular disorder, glycemic control, drug-drug interaction, vertebral fractures, are all more seen in patients with acromegaly and significantly impact on COVID-19 outcomes, as you've seen. We also focused recently on how are we able to maintain the multidisciplinary management virtually. And as you've seen, we need many doctors for these patients. So initially, after the COVID-19 pandemic was declared by WHO, we started the process, an international process, to discuss an individualized approach for patients with acromegaly, to include the medical treatment more upfront for some patients that were not able to have surgery due to the pandemic. And there were several medications, some of the one that I mentioned earlier, but it was a focus on training of patients and family members to administer injections themselves instead of coming to the hospitals that were semi-closed, as you know. Also, we have used more pegvisomant as first-line therapy because this is a sub-Q injection with gradual dose titration. And sometimes, though no regulatory approval, we added cabergoline a little bit earlier. A survey looking at healthcare professionals from several countries looked at how many of you have been effective in taking care of patients with acromegaly. And as you can see, 44% said that they had difficulties diagnosing the patient. Assessing them after diagnosis was more than 50%. And then both labs and imaging, mostly MRI, have been affected too. How about patients? When patients, and the number was even higher, were asked, have you been impacted? So these patients were not patients with COVID, were patients with acromegaly during the pandemic overall. And more than half reported an impact that they couldn't see the doctor, it was postponed. As you see, surgery canceled in up to 10%, limit on medication, and could not access the hospital pharmacy for medicines. So in conclusion, we have new data on patients with acromegaly, therapies that are effective and can improve symptoms. We have to keep in mind that many of these patients are on multiple medications and have multiple comorbidities, so we have to find the right treatment for them. COVID and patient care and physicians and patients' perspective are both important. And furthermore, the comorbidities in patients with acromegaly can impact the COVID-19 outcomes, and we have to think about all this. And the multidisciplinary approach that we all like and need for these patients, the ENDO 2021 data adds to the knowledge needed by all specialists to be an effective team. Thank you so much, and looking forward to hear from any of you if you have questions. Thank you.